I'm Dr. Louis Blevins at Pituitary World News, and we're here at the 2025 Endocrine Society Meeting in San Francisco, California. And I'm fortunate enough to catch up with Dr. Susan Phillips, who's a pediatric endocrinologist at the University of California, San Diego. Thanks for joining us this morning for
Happy
this interview.
to be here.
It's good to see you. I really enjoyed your presentation yesterday on Setmelanotide for hypothalamic obesity. I'm really excited about the prospects of having this drug in our hands to treat our patients with hypothalamic obesity due to different causes. I wonder if you would share with us some of the underlying physiology behind hypothalamic obesity. Then we'll talk a little bit about the drug and the trial results that you presented.
So setmelanotide is really easy to understand because setmelanotide is an analog of alpha MSH, which is a hormone that binds a receptor, and that receptor activity signals satiety. So in endocrinology, it's just what we all learn, that we learn about ligands and their receptors and what to do when one or the other isn't working. So in this case, alpha MSH isn't there because of damage to the hypothalamus. And because it's not there, it can't signal satiety, and therefore we get hyperphagia. Setmelanotide corrects that by being that ligand, binding to the melanocortin-4 receptor and signaling satiety.
It seems like there's some evidence that you may also increase metabolic rate or autonomic outflow to increase metabolism as well with this medication. Have you seen that in your experience?
Yeah, I think that's a more nebulous thing to pick up, but I do in talking with patients, I think one anecdotal case would be good here. So I had a patient with craniopharyngioma, and she is on setmelanotide, and I asked the mom and her about her activity level. And they said it's kind of hard to describe, but before she went on this medication, mom set her alarm for 8 and at 4. And at 8 a.m. in the morning, she told her daughter, we need to go out and walk. And the daughter would always say, I don't want to, I don't feel like it. And at 4 p.m., she would have the same response. On setmelanotide, the daughter is getting the mother up to go out for a walk at 8 and at 4. She's walking more, she feels more energetic.
That's very interesting.
Mm-hmm.
So the types of illnesses that patients have with hypothalamic obesity may be pretty much the same in your practice and mine, you being pediatric,
right.
being adult endocrinologist.
Yeah.
Craniopharyngioma is probably the most common.
Yeah, craniopharyngioma or germ cell tumor. The common denominator is injury to the arcuate nucleus. And those neurons in the arcuate nucleus make the alpha MSH, which is released in the paraventricular nucleus a little bit away, where it acts on that melanocortin-4 receptor. So anything that destroys or reduces the amount of alpha MSH might be amenable to management with this drug or drug type.
So you participated in the trial. Can you tell us a little bit about the magnitude of results and side effects and things of that nature?
Oh yeah, I'd be happy to. So the primary efficacy endpoint in this trial was the mean % change in BMI in subjects at 52 weeks versus baseline, and that compared in setmelanotide arm versus placebo. And there were 120 patients that were randomized 2-to-1 to the setmelanotide, and it was 60 weeks. And we now have patients on an open label extension because those having the 60-week end of trial visit were offered the opportunity to continue in that open label extension. Of the 120 patients that enrolled, we had 106 complete the 52 therapeutic regimen, and we had 14 discontinue for adverse effects, 9 on setmelanotide. And the most common adverse events on the setmelanotide arm were hyperpigmentation or GI effects. Some people also reported headaches. The hyperpigmentation is from melanocortin-1 receptor agonism, and so that's expected and seen in this drug in prior treatments, as are the GI effects. There's only one really serious adverse event on the trial, and that was a patient who had hypernatremia. And with treatment, that patient recovered in 2 days. There was a death that was not related to studied drug in a patient who had a seizure disorder. Basically the safety was consistent with prior studies with setmelanotide in other rare disorders of obesity.
And the proportion of patients who responded, and talk about, I saw the percent changes in BMI. Help the audience understand what those percent changes in BMI might translate to for amount of weight lost as well.
Yeah, so I had a 14-year-old subject that I was seeing in my group, and she lost 80 pounds. It was life-changing for her. I had an adult patient who lost about 100 pounds, and she said that she used to be anxious about going out in public to eat because she was hungry, and it was so hard for her to feel full, and everybody would look at her. And so she would be sitting at the table, a very large woman, eating a large amount, and have societal disapproval. And now she can go out to eat, and she knows she's going to get full, and she looks better, and she feels better. So the delta, the placebo adjusted difference in the setmelanotide to placebo group was about a 20% weight loss. And 43% of those in the setmelanotide arm had greater than a 20% BMI reduction. So it's really a significant amount of weight loss.
That's pretty incredible.
Yeah.
I think our patients are going to be delighted to have similar responses once this drug's approved. Yeah. What do you think the next phase is? Do you think there's enough data now to get an approval from the FDA, or does that remain to be seen?
Well, those are for the people at Rhythm to do the submission. I'm just one of the site PIs, but from what I'm seeing and the response in the patients, I'm hopeful that they'll be successful.
Very good. Yeah, me too. Well, I really appreciate you joining us today. It's great to chat. Great to meet earlier today.
Yeah, thank you. Thank you for the opportunity.
Neighboring institutions through the same board of regents. It's nice to meet a colleague. So thanks once again.
Well, thank you.
All right. And thank you folks for joining us today.